Welcome everybody to AO North America Link, the first initiative directed solely at medical students. So welcome. I know most of you are third and fourth year medical students, probably entertaining the idea of going into orthopedic surgery. I know we also have some veterinary students, dental students, etc. So welcome to all. We're real excited to be here. This has been kind of a dream of ours and mine for many years now, trying to put this together. This organization, which you'll hear more about as the evening progresses, AO, or Arbeitsgemeinschaft Osteosynthesfragen, which was founded back in 1958. This has been a very important part of my career, my life, the co-faculty as well. You'll hear more about its origins and importance in our careers as the night progresses. But we never really had an initiative directed at medical student learners. And as you progress through your careers, most of us in academic medicine, we work with medical students every day, and we realized that there was a real need for some sort of an organization to really grab the bull by the horns and start teaching for the medical students. And so many of you have already chosen a pathway or a career directed at orthopedics. And so this is really designed for you. So what is AO Link? Well, it's a cute combination of letters that stands for listening, integrating, networking, and knowledge. You'll see that through your career, you're going to want to talk a lot, but perhaps a lot of times it's more important to listen. You're going to integrate what you hear into your hands and what you learn. A lot of what we do is about networking and who you know and the good times that we all have together. And ultimately, as you achieve that knowledge, passing it on to the next generation. So welcome to everyone. We're excited to be here. I'm Tim Aker. I'm the chair of this program. I work at UT Houston. I'm an orthopedic trauma surgeon. I've been here now 14 years. Very excited to be here. We have this quote on here at the bottom that as you begin your career, there is nothing more important than your foundation of knowledge. Keep in mind that every night you might go home and you might want to watch the football game or go out to dinner, and that's great. You have to do what you want to do. But some of your colleagues are going home and opening textbooks and reading journal articles and reading and learning. And as you begin your career, the foundation of knowledge upon which to build upon is really paramount. It's so critical because a few years from now, you're not going to be able to read more and get caught up. So it really starts early. So the foundation is so critical. And that's what these next 10 sessions are about. So with that, welcome everyone. I'm so excited that you're here. And I'm going to turn it over for my co-faculty to introduce themselves as well.
Yep, welcome everyone. My name is Phil Mitchell. I'm an orthopedic trauma surgeon at Vanderbilt, and I'll be with Tim and with Taylor with y'all for the next 10 months. And I'm going to kick it over to Taylor to introduce himself as well.
Hey everyone, we're glad you could join us. My name is Taylor Young. I'm an orthopedic trauma surgeon at Texas Tech University Health Science Center in El Paso, Texas. A little bit of a mouthful, but we're excited that you're here.
So I want to start tonight by introducing y'all to our featured faculty, and that's Christian Payon. And so Christian, why don't you introduce yourself, and then also to this group, maybe give some of those tuning in your best tip or piece of advice for a medical student who's rotating onto your service.
Absolutely. Very happy to be a part of this. I'm Christian Payon. I'm an orthopedic trauma surgeon at Duke University School of Medicine in Durham, North Carolina, and a faculty member at the Duke Margolis Health Policy Center here. I think this is going to be a great program. I think that it is sub-I season right now. And what I'll say is, as you're going through your rotations, I think my piece of advice to you is to absorb as much knowledge as you can and show that you are willing to be a good team member. Orthopedic surgery is a team sport. And more than anything else, we are looking for people to be part of that team when you come and rotate with us. So that's my advice, and excited to be part of this.
All right, thanks, Christian. So here's the agenda for the year, and the goal of these webinars really is twofold. First, we want to provide you with a basic framework to understand how and why we're fixing fractures, how they heal, and understand some of the history leading up to what we do today. And secondly, We want to provide you with the tools to first really shine on your orthopedic rotations, but more importantly, how to get the most out of those rotations. So many of you, regardless of what specialty you're going to choose, will be fixing fractures, and the concepts we start discussing tonight are going to carry you throughout your entire career. So we formatted the lecture series in that way, hitting major topics in fracture care, starting with the building blocks, which is tonight about how bones heal, and then followed by increasingly complicated topics. We want you to understand better what's happening in cases, what's happening in clinic, have the knowledge to start making some of your pre-op plans, and then also get you a little bit more familiar with the language of orthopedic trauma. So all microphones are off, but we highly encourage questions through the Q&A box on the bottom, not the chat box, the Q&A box. So this is your time to get that burning question out there that you didn't want to ask in the middle of that case that wasn't going so well in an anonymous forum. And Taylor is going to be answering those and sifting through those and presenting them. So as a reminder, check your email for the link to claim your Credly badge after the session. Then all these webinars are going to be available on YouTube. So tonight we're going to talk about how bones heal, and some of the basic building blocks for understanding why we do what we do is based on the concepts presented tonight. And Taylor, Christian, and I are going to go over case after case, both because it's fun, but also because it cements some of these fundamental concepts. And in addition, many of the concepts presented tonight are going to be common pimping questions during your fracture cases. We want you all to look good, so I'm going to highlight those as well. So the objectives are as follows. First, I want to improve your ability to describe fractures. We're going to go over a simple approach to describe a fracture that will keep you accurate and safe. Secondly, we're going to develop a framework for how bones heal. We're going to apply that framework to some fracture cases. And then lastly, I want you to understand how we got here. Keep an eye out for the yellow star here. These are Mitchell hot tips. Take your game to another level. So we're going to start with a case tonight, and I just have a few questions. So this is a 53-year-old male. He was in a motor vehicle collision and he sustained this injury. So my first question would be, how would you describe this fracture? You may get asked tomorrow in a fracture conference, what would you say? Secondly, how are you going to fix this? What implant might you use? If you're going to use a plate, how long is the plate going to be? How many screws do you need? And then lastly, how are these fractures going to heal? By the end of the session, you'll be able to start answering these questions, and this is going to form the basic framework for a lot of our discussions in the following session. So we're going to start with the first objective, and that's just how to describe a fracture. And so many of you all will be on trauma rotations, and even if you aren't, you're going to be asked to describe an X-ray at some point. We're going to use this mnemonic right now, Walter. Walter just happens to be my X-ray tech, and while he looks like he just left Woodstock a few minutes ago and he breeds koi in a pond in his backyard, the man can sling X-rays like none other. And so Walter is meant to be used when you're in a fracture conference and this X-rays is shown and you're asked, what do you see? So first, W stands for what is the image? Here you're just assessing what film you're being shown. So the first words out of your mouth for this image should be, this is an AP X-ray of a right femur. Perfect way to start. Does two things. First, buys you time to start to gather your thoughts. And secondly, you're almost always going to be correct. Next is A for age. So here you're assessing the skeletal maturity of this patient. So I've identified the distal femur fracture that's obvious in this radiograph. But don't forget to highlight that this patient still has open growth plates. And this is going to be huge in terms of implications in the ultimate treatment. Next is L for location. So we've identified the X-ray. Now what is broken and where? And this may involve terms like diaphyseal or midshaft, distal or proximal. T stands for type of fracture. And here you begin to characterize the fracture. So appropriate terms, comminuted, transverse, oblique. This AO classification scheme I'm showing here may be helpful to review. The top row are fractures that are simple or just two pieces. So based on the orientation of that fracture line, you can describe it as transverse, as oblique, or as spiral. For our purposes tonight and for your rotations, all patterns below this are comminuted or can accurately be described in that way. Next is extension. So you've identified the distal femur fracture, you identified the location, the character. Now is there extension into the articular surface? So this X-ray could accurately be described as a comminuted distal femur fracture, but the intra-articular extension is a critical finding and is going to prompt advanced imaging and may affect the ultimate treatment. And then lastly is associated injuries, and this may be your time to shine. You've identified this comminuted midshaft femur fracture. You don't see extension proximal or distal, but you know that femoral shaft fractures have an association with an ipsilateral femoral neck. So you assess the neck and identify a fracture and finish with your description with, I also see a non-displaced associated femoral neck fracture. So hot tip, Mitchell hot tip, here we go. If you know an associated injury and it's not present, that's okay. This is still an opportunity for you to shine. In this case, if you assess the neck and don't see it, you say, I don't see an associated femoral neck fracture, but I want to see the CT scan to look further. So we're going to bring it all back together at this point. I'm going to go right to Taylor. And Taylor, bring it together for us. How do you want a medical student or a resident to describe this injury pattern? What are some of the initial thoughts that you have looking at this?
Yeah, so I think using your framework is incredibly useful. What I would say, what is the image? We have two views, or you could say an AP and lateral of the tibia. And then you can basically describe what you're seeing there as well. And you can talk about age of the patient occasionally is relevant. Sometimes it's not so relevant, but I like your idea of it buying you some time to think further. And then location of the fracture. So I would say this is two views of a distal third tibial shaft fracture. And there's also a comminuted proximal fibula fracture. And then at the same time, you may be wondering if there's extension elsewhere. In these sorts of injuries, we do sometimes worry that there's extension distally into the articular surface. And so that falls into your related and associated injuries qualifier there. And so we may want some advanced imaging to look at the ankle to see if there's intra-articular extension.
Awesome. So much to take out of that. And coming back to what Dr. Aker said at the beginning, if y'all are reading at night and you start picking up some of this knowledge, associated injuries, you can demonstrate that you're reading in a way that is not out front, but is clinically helpful to the patient, and will demonstrate that you are an excellent medical student and doing extra reading on the side. So I think it's an excellent way to sum this up. And again, just remember Walter, koi pond, deadhead, Walter, it'll help you. So we're going to, at this point, transition. We've got this basic framework for describing fractures, and I want to get into our discussion about bone healing. And I'm just going to start by showing these two x-rays, both bones that are healed. And you'll see there's a dramatic difference between these two pictures. The radiograph on the left shows a plated humerus across a fracture that's not visible anymore. The fracture appears to have healed, and to the point that there's really no sign that there ever was a fracture. In the picture on the right, you see there's a fracture that is healed with bridging bone. And in contrast to the picture on the left, it's obvious that there was a fracture. There's evidence of new bone tissue outside of the normal contour of the humerus, and the bone no longer has the same morphology. So why did these two bones heal differently? The plate lengths are different. There's a different number of screws as well, but one healed without extra bone formation and looks like the intact bone before it was fractured, and one healed with extra bone that forms a bridge across the prior fracture. So both represent healed bones through different processes. We're going to review this tonight. The bone on the left is healed through a process called primary bone healing, and the bone on the right is healed through a process called secondary bone healing. So to start, while fractures have healed on their own for thousands of years, what we do as orthopedic surgeons affects the way a bone heals. So in these radiographs, all started out as proximal femur fractures and are now healed. But how we got there, the method the bone healed, was dependent on a number of factors. And so the method of bone healing is dependent on, first, the type of fracture, secondly, how the fracture is reduced, so the type of reduction, and then lastly, the stability imparted by the implant that you are choosing. So here are the events in fracture healing. A fracture occurs, and after traction and splinting, we finally got clearance from trauma. Everybody's okay to go. Surgical intervention ensues, resulting in either primary or secondary bone healing. So we're going to focus on primary bone healing and how this is achieved. So to achieve primary bone healing, the fracture type needs to be a simple pattern. So back to the initial description, either transverse, oblique, or spiral. And so when you're presented with a simple fracture pattern and you want the bone to heal by primary bone healing, simple pattern, you need an anatomical reduction. And what that means is you're visualizing the end of the fractured bone. You're cleaning them, you're reducing them or lining them back up anatomically like the bone was never broken. And then lastly, once you've reduced it or put the bone back together, you have to fix it. If you want primary bone healing, absolute stability is required. And this last term we're going to go into just a little bit more. Absolute stability means no micromotion at the fracture site under normal loads. And again, this requires an open reduction or seeing the ends of the bone that are fractured, putting them back together, and then restoring the anatomy of the bone. With an anatomic reduction and absolute stability, primary bone healing typically occurs. So to get primary bone healing, there needs to be direct contact between the ends of the bone. And in this setting, without motion, internal remodeling occurs and osteons heal across the fracture gap that's shown in this photo micrograph. No callus forms in this scenario. So there are a number of ways to achieve absolute stability. The main three we'll discuss are lag screws, axial compression through a plate and buttress plating, and a teaser for next month with Taylor. He's going to go into these in much greater detail as well. So as an introduction, first, interfragmentary compression or lag screws. So these are typically used in the setting of an oblique or spiral fracture, where a screw can be placed directly across the fracture at a 90-degree angle to the fracture, and by drilling with a different diameter drill, compression with the screw is achieved. So here's a case. This is a lateral view of a left forearm. It demonstrates fractures of the radius and ulna at the proximal 1/3 level. The fractures appear oblique, so type, very critical to determining which kind of bone healing we're going to go to. So the fractures are oblique, simple pattern without extension or associated injury. Because it's a simple pattern and we want to heal with primary bone healing, the fracture is exposed. We open the forearm through an approach. We visualize the fracture, we clean it, and then we reduce it with these clamps, and a lag screw is applied at a 90-degree angle to the fracture. We then apply a plate to neutralize the forces around the screw, and the patient goes on to uneventful union. A second way to achieve primary bone healing is through axial compression using a plate. So this technique is going to be used in the setting of a transverse fracture where you can't get a lag screw that's 90 degrees or perpendicular to your fracture. So again, Taylor's going to hit on the details of how to do this next month, but compression can be achieved by placing a screw eccentrically in one of the holes of your plate. So another case, AP film of a both bone forearm fracture, distal third, transverse pattern. We're going to look at the ulna only in this case and see that there's no good trajectory for a lag screw. To go perpendicular, we have to go down the intramedullary canal of the ulna. So in this case, a plate is applied and it's used to compress across the transverse fracture. So lastly, we're going to discuss buttress plating. And so this is the last way to achieve absolute stability that we're going to discuss tonight. This is useful in injuries that are secondary to a shear force. So in this AP view of the left knee, we see a displaced lateral tibial plateau fracture because it involves the knee joint, and we want to restore the anatomy of the knee and diminish the risk of arthritis. We open, reduce, or visualize the fracture, and a buttress plate is applied to the lateral knee. So I included this fluoroscopic shot in the upper right-hand corner for a reason. A common intraoperative question when fixing these is which screw goes in first. And so, hot tip, I want you to remember this image. When asked, it's the axillary screw, or the screw that's right below the exit of the fracture. So the clinical indications for absolute stability, and we've gone over this to this point, so y'all should really be feeling it now, but this is articular fractures. This is simple diaphyseal fractures, commonly in the upper extremity. And then this is some simple metaphyseal fractures. So lastly, very important to highlight, even though we're opening up a fracture, visualizing it, looking at it, cleaning it, putting it back together, we want to ensure that we're taking care of the vascularity of these bones, because bones only heal with blood supply. And in this setting, we want to limit our stripping just to the fracture site itself, not more proximal or distal. So we're going to transition now to some cases, and I'm going to go ahead and just loop Christian in. And so Christian, this is your patient. It's a 26-year-old. We've gone over one way to describe a fracture. You've got a new medical student in your clinic. You've got a junior resident. How do you want them to describe this? And then what's your thought process about how to get this bone to heal?
Definitely. Yeah. Thanks, Phil. I really like your system. Here I see two views of the right humerus and a skeletally mature individual demonstrating a transverse distal third humerus fracture that does appear to be displaced. I'm not seeing any other associated injuries. This is a patient that I'm wondering a little bit about their neurologic exam. All right. Going off of the patterns that you've discussed today, again, simple fracture. I do think that this is something amenable to absolute stability, but perhaps not a lag screw, compression plating, or another kind of fixation technique that confers that absolute stability and promotes that primary bone healing. That's what's going through my mind when I see this fracture pattern.
That's awesome. I think a couple of things I want to highlight with what you said. And in particular, we talked about associated injuries, and you mentioned a radial nerve palsy, and coming back to that reading and knowing associations. This is a perfect opportunity. You can say an associated injury is a soft tissue injury as well, to say it's a distal third humerus. I know there's a close proximity to the radial nerve here. I'd be worried about that as well. So great opportunity for you to show that knowledge. So we're not going to get too much into the indications for when you fix a humerus or not. This is a patient who had an acetabular fracture, and we chose to fix the humerus as well, help with mobilization, allow some early weight bearing. And so here's some fluoroscopic shots. And just again, we're going to address some of this in the humerus webinar down the road, but this is one of my favorite techniques to reduce these. This is a clamp that we straighten the tines out, make in new drill holes in the bone, and you can use this clamp to hold the fracture reduced while you then apply a plate. And then you fill the plate with screws, and the bone is reduced anatomically. So Christian, any thoughts? How did we do? And then do you really think it's going to heal with primary bone healing, or do you think I'm gonna have a little bit of callus a year from now that maybe I didn't get it as good as I thought?
I think you got it pretty well aligned. You compressed it. There is this just tiny spot of comminution that we see immediately that makes me think that there might be some callus that forms, but I wouldn't be surprised if this healed with complete absolute stability and primary bone healing. Yeah, I'd be excited to see the follow-ups for this one.
So we got it right. I've definitely got a little series of those that have some callus that formed, and but this one did heal without callus. She went on to uneventful union and is back at her job at the Nissan plant or something like that. So
Bill, can I just ask you a question that my PA asked me when we started working together 15 years ago?
Yeah.
Because she would see your x-ray on the right and she would be concerned. She'd say, well, there's no callus formation, so I'm concerned that there's a non-union. How do you know with absolute stability? How do you know when a fracture is healed?
Great question. I think you will see some bridging across. I have a few patients that come to mind that if they still have pain, we will get a CT scan to look. And sometimes the plane of the fracture, in this setting, it's transverse, so the x-ray is going to shoot right down the transverse fracture. I'd expect to see it, but sometimes it's not. If it's an oblique pattern, you get an x-ray, it may look healed, but it's not. But I think pain is a huge indicator, and I think that would be what would guide advanced imaging to look for that. So, Tim, can I ask you a question right back?
Sure.
Are you transverse humerus like this? I did 4 screws above, 4 below to allow her to weight bearing. Is that overkill? Can you get too much absolute stability? What's your go-to? Are you 3 above?
Again, depends on the indication. If this is just an isolated injury and the patient's uncomfortable and wants it fixed, probably 6 cortices above and below, or 3 bicortical screws above and below is probably plenty. But to allow them to really use crutches or a walker and get up and move, this construct makes me feel a whole lot more comfortable. But also, it's not just slapping a plate on the bone and putting in screws and high-fiving. You're not even really getting into the weeds of, you're asking this implant to do something. This is compression plating, the hallmark of absolute stability. The hallmark of primary bone healing is compression. So, I mean, it goes without saying that you absolutely compressed this fracture when you applied the implant. So you didn't just contour plate and put some screws in. This plate is actually working to get the beautiful result that you got on the right.
Yep. And again, a teaser for next week, we compress with that clamp, but then we're drilling in a way into the plate to compress even more. And y'all will be in cases where you'll see the fracture juice squeeze out and the fracture line just dissipates just a little bit more. And there are a few things more glorious than that. So absolutely an important part to compress and get some fracture juice and turn the music up, and it's just a really good time. So
We call that the AO Kool-Aid, I think, right?
that's right. That's right. So I'm going to go to another case here. I'm going to get Taylor's thoughts on this one. So Taylor, how would you want this presented to you, and what would your approach be for this particular injury?
Yeah, so this is a single view AP of the distal femur, sort of giving a sense of the knee here as well. And we're looking at a skeletally mature patient. There's a somewhat oblique fracture of the distal femur that appears to quite obviously extend into the knee joint there. It is a bit difficult to see what's going on as the fracture is somewhat obscured by the patella. And so potentially additional imaging would be useful to clarify if there's any comminution at the level of the joint or where the fracture line exits at the joint. And so I would recommend a CT scan, as you've shown here, a variety of cuts to better define this injury.
Nice. In terms of bone healing with this, what would you be trying to achieve? Is this a primary bone healing case for you? And we went over some different implants to use. Is this one that you could treat with compression plating?
Not necessarily. So like you said, the strategy here would be it's an articular injury. So we want absolute stability and an anatomic reduction. We don't want a patient's patella riding through that big defect. It's got to be perfect. And so essentially we want to visualize this fracture, anatomically reduce it, and then get absolute stability through our construct. Like you said, there's a variety of ways to do that from screw techniques. But I think this is what we would call B-type fracture, partial articular fracture, and a B-type fracture begs for a buttress type plate with that screw at that nice apex that you demonstrated previously.
Excellent. So here's a few fluoroscopic images. Again, you see that screw being placed at the apex first. So right proximal to the fracture apex. And so here's the final x-rays with buttress plating, anatomical reduction. This patient is now about 6 weeks out, but because of the stable fixation and anatomical reduction, she's been moving her knee since day one. And so we're avoiding stiffness in the knee. We're optimizing her or decreasing her risk of arthritis, and she's on track for an uneventful recovery.
Hey, Phil, let's get a little crazy here.
Here we go.
Let's answer a question live. Michael Foley's got a question. Does the placement of a plate affect muscle function due to its location with regards to the muscle origin and insertions? So what do you think? Does the plate application, can it affect muscle function?
I think commonly when we're talking about applying plates to the bone, they're most effective, like in this case, with a plate right on the bone surface. And with one of the reasons I use this particular plate, it's a very thin plate. So we could have used the big bulky distal femur plate, but I'm not necessarily worried about muscle function, but more about prominence of the plate and tenderness around the plate secondary to that. So we don't see much muscle dysfunction, at least I don't feel like I do, because of plates, because the muscles are running in line with the femur and in line with the plate, but you do see implant prominence. And so this is a great case to bring that up, where we chose a different plate because it's thinner, she's thin. I don't want to have to remove it unless absolutely necessary.
Yeah, if I can, just to build on that and speak to Michael's question here, there's also definitely anatomic considerations when we're placing this plate. I don't know about Taylor and Phil, but for me here in this patient, we're probably doing a subvastus elevation, and placing the plate underneath the muscle in a place where it's not going to affect the muscle function as much because it's directly on the bone. And our dissection does try to spare muscles, I think, and are placed in a strategic place for fixation.
Great, thank you.
Awesome. So the take-home messages from primary bone healing: absolute stability is the goal in simple fracture patterns, which can be reduced anatomically. So absolute stability, no micromotion at the fracture site. These fractures are expected to heal without callus through the process of primary bone healing. So any other questions, Taylor, from the chat box on that before we move on?
Yeah, I think there's a couple of questions that are looking at some comparisons between primary or absolute and relative stability and primary and secondary bone healing, and sort of this. I guess one of the questions is about the strength and durability of healing in primary versus secondary. And then another one is asking about recovery time, comparing the two. And, I think, at least from my perspective, what I would say is it's difficult to compare some of those things because every patient is so different. And there are so many variables that will ultimately impact their healing time and their overall recovery, as well as this, stability of the construct is a spectrum, and these aren't sort of binary events. It's more of a spectrum. And so I think people are maybe having some trouble in like getting the full differences between the two, but it's really more of a spectrum. I don't know if you feel like you could elaborate on any of that at all.
Yeah, once the bone's healed, it's healed. I'll say that in my mind. And then secondly, in terms of recovery, hard to compare because more complicated comminuted fractures often are more high energy fractures, which may have more associated soft tissue injury. So it's difficult to compare. That doesn't necessarily come into my consideration for recovery, choosing one or the other. It's more, how am I going to get this bone healed in the most respectful way to the soft tissues, and in a way that is going to be the highest rate of union, it would be my thought process for that. We'll go through some of the secondary bone healing cases as well, and I think that'll help to have a comparison. So. Okay, so now we're going to talk about secondary bone healing, and secondary bone healing is going to be in the goal in the case of complex fracture. So everything below that first row in the initial fracture description is a complex fracture. So in these cases, instead of anatomic reduction, our goal is anatomic alignment or functional alignment. So simply, instead of restoring the anatomy of the bone by lining the fracture up, we want to restore the alignment of the bone. So this means restoring the relationship between the top of the bone and the bottom of the bone. So the leg is the same length, the foot's rotated on the leg correctly and pointing in the right direction, and then also matching our coronal or varus valgus alignment as well to the other side. And so the type of stability we're going to be using in these cases is different. And so instead of absolute stability, we're using relative stability. So relative stability indicates there's some motion between these fracture fragments. So to achieve this, we're going to be using flexible fixation like this intramedullary rod or bridge plating technique. And so now, importantly, the motion between the fracture fragments must be below the level of healing tissue so that the newly formed bone isn't disrupted. So additionally, indirect reduction techniques are used. So when we're trying to get the leg the same length and the same rotation, we're not visualizing the fracture. We're comparing it to the other side and then using traction, ball spikes, other tools to get that reduction. And then with relative stability, secondary bone healing occurs, which is characterized by callus formation. So the indications for use of relative stability are going to be non-articular multifragmentary fractures. And this makes sense. So shown here, highly comminuted femur fracture. You can imagine trying to put all these little bits back together of the femur. It may not be possible. I don't think I could do it. And secondly, it may result in too much soft tissue damage to all these pieces. So in terms of the primary versus secondary decision, primary is not an option here without creating more damage and increasing this patient's risk of not doing well. So for that reason, we span the area with an implant that has some flexibility like a rod and allow it to heal on its own. We're not interested in anatomical reduction. We're interested in anatomical alignment or functional alignment to making sure this patient's leg's the right length, the foot's rotated properly and the alignment's correct, and we expect it to heal with callus. So secondary bone healing works because there's multiple fracture sites. The strain is diminished or distributed across these sites, and callus forms and eventually results in bridging bone that's shown in this series of pictures. So There are multiple methods to achieve relative stability, and most commonly, y'all are going to see a plate or a nail, but traction, cast, external fixation are all ways to achieve relative stability. So first, traction, not seen much anymore outside of being used to temporize femoral shaft fractures or acetabular and pelvic ring injuries. But traction used to be the workhorse for femoral shafts. And so this picture shows the unbelievable progress that's been made over the past 100 years. So from a traction bed for 6 weeks to now putting weight on your leg the day of your intramedullary nail, it's unbelievable. Casting can absolutely also be used, and I'll use this occasionally for some certain clinical scenarios. For example, this is a tibial shaft fracture in a patient that had some pre-existing wounds on the leg. We elected to treat her in a cast. This is her at 3 months. She has callus formation, has drifted into some malalignment as well, and eventually underwent correction. But you see, she has callus formation. If we kept treating her in a cast, she would go on to heal in malalignment.
I would say, Phil, if I could just interrupt, one way it was taught to me back in the day, if you go back a slide, that relative stability and all this callus formation, this is really nature's way of healing. Nature cannot heal a fracture with primary bone healing. There's no way for nature to get compression across a mid-shaft fracture. So over the natural history of man with, bamboo splints, etc., going back hundreds of years, this is how fractures have healed historically with non-operative means. A little bit of malalignment, shortening, malrotation, and lots of callus formation because of all that motion that's happening at the fracture site. Nature's method of fracture healing.
Awesome. So external fixator is most commonly used to temporize and allow soft tissue swellings to go down, but also could be used definitively. So a patient of mine with a P-line placed an external fixator device shown here, got lost to follow up a little bit, came back, and you can see here he's got callus formation, and we ended up treating him definitively in the X-fix and removing. So bridge plating is what we're going to see most commonly, in addition to nailing, in terms of treatment of these comminuted fractures. And that's a lot, realigning the distal end of the bone to the proximal end so that length, alignment, and rotation are corrected, and then allowing all these comminuted bits to heal in with calluses demonstrated here. And then lastly, intramedullary nailing, which y'all are almost certainly familiar with, and that involves placement of an intramedullary device and callus formation. So the final point I want to make, when discussing restoration of anatomical alignment, you'll commonly hear these important words: length, alignment, rotation. This is restoration of that functional alignment. In this case, that means getting x-rays of the other side prior to fixing so that you can make sure these 3 parameters are symmetric. So a few more cases. Christian, another humerus I have for you, a little bit different from the prior case. So how would you describe this one, and is your approach going to be different at all?
Yeah. No, this is going to be a nice one to contrast to the earlier case. So this is 2 views of the left humerus in a skeletally mature individual, demonstrating a comminuted distal humerus fracture with several intercalary pieces. I don't appreciate any other injuries on this imaging, and I don't see any extension into the joint. When I see this fracture, I'm less certain that I can achieve absolute stability and compress each one of those individual fractures. When I see this pattern, it's not simple, it's complex, it's comminuted, it's not in the joint. So that's a place that I think is appropriate for secondary bone healing. I'm thinking bridging or spanning this fracture and getting a functional reduction where I restore length, alignment, rotation, and expecting some callus and secondary bone healing with my final construct, likely some sort of an extra-articular humerus plate that bridges the fracture. That's what I think when I see this this pattern.
Awesome. So similar thought process, fracture more comminuted, fits within that bottom group of the complex patterns. And so because of that, we're going to treat with relative stability and expect some secondary bone healing. So in this case, a plate is applied. You'll see some additional position screws in here. And again, just next month, we'll find out a little bit more about position screws, lag screws, what's the difference. We have some position screws, but you can see that we're not anatomically reduced. There's a fragment in the front that's not captured by screws. The alignment seems good, but the bone doesn't look like an intact humerus. And so in this case, the patient heals with callus, and at 4 months, essentially healed. So Taylor, another one for you, another femur, a little bit different than the first one. What would your approach in this case be? How would you describe it? How would you treat it?
Yeah, so we have three views or three X-ray views here. There's one that is sort of focused more on an AP of the proximal femur. The middle X-ray is a AP of the more distal femur, and then a lateral of the distal femur as well. You can see there is a bit of comminution at the fracture site. And so this is a sort of fracture where there's a lot of comminution. There's a lot of muscle overlying all of that tissue. You probably don't want to go in and try to piece together every little fracture there and fragment and potentially devitalize those fragments. And so the goal here, I think, would be a relative stability construct. And in this case, probably the most soft tissue friendly option would be a intramedullary device of some sort.
So exactly, one of the greatest cases in orthopedic surgery for a fresh intern or fresh to an intramedullary nail. You can see it's fixed with a retrograde nail and at 1 year healed with callus, doing well. So take-home messages from relative stability, non-articular multifragmentary fractures. Again, these are fractures that the idea of primary bone healing is going to create too much damage to those fracture fragments, increase your rate of the bone not healing. So we're applying our implants in a way that's allowing a small amount of motion. This may be through plates, nails, but also includes X-fix, casting, maybe traction. And then these bones heal with relative stability with callus. So Taylor, any questions in related to that in the chat box?
Yeah, I think there's a good question as far as mechanics and how absolute and relative stability relate to strain.
Okay, can you give me just a little bit more detail?
I think sort of the idea I would say is that absolute stability is associated with a bit less strain, and then relative stability is a bit more strain, but not too much strain still, you know.
So I think we'll get into that a little bit without getting into the weeds when we talk about implants. But one way to describe it, to decrease the strain in an absolute stability case, we put screws close to the fracture to decrease motion. In a relative stability situation, you'll notice the screws are further away from the fracture, allowing some motion across the fracture fragments. So if a fracture is highly comminuted, if you make it too rigid and put screws really close or load the whole plate up with tons of screws, you may compromise your ability to have that small amount of motion at the fracture site that's going to promote secondary bone healing.
Another question is about weight bearing and absolute versus relative stability.
Totally a case-by-case basis, an implant-by-implant basis too. So it's hard to say because a femur will treat a femoral nail. It's highly comminuted with an intramedullary nail. It's a load sharing device. So both the implant takes on some of the load as well as the bone. And in those cases, most folks can weight bear as tolerated. In a comminuted humerus, where I'm plating it, it's probably less likely to allow that to weight bear because the stability is not as high as with an absolute stability, screws close, anatomic reduction. And so I'd be less likely to, but it's going to be case by case basis. And it's probably surgeon by surgeon basis as well. What do you think, Tim?
I got to say, I'm just, I got tears in my eyes about all the questions, all the level of engagement from all the learners, the inquiring minds want to know. Just so awesome. I mean, the only other thing I was going to say about relative stability is that we kind of glossed over the fact that long bones of the lower extremity, specifically femurs and tibias, diaphyseal or shaft fractures of the lower extremity always do well with nails. Okay, not always, not every time, but in general, they should be treated with nails. You can allow for early, immediate weight bearing, and greater than 90-95% of the time, they're going to heal. It's one of the most successful operations that we perform. So while I understand considerations for a simple fracture pattern for a femoral diaphyseal fracture, I don't want the students to start thinking too much down the rabbit hole of, well, that could have been treated with a plate. Because yes, it could be, but when you have success of 98% with nails, don't think plates. Think nails for femurs and tibias. That's all.
Great point. And we'll hit some of that when we hit femur too, because I think seeing the history and the evolution of how we got to where we are now, to say actually nails do an incredible job.
So true. I love that point. Yeah.
So I'm going to just finish before we finish and get on to some more cases. I just want to spend a few minutes talking about the history of the AO Foundation and how far fracture care has come from the beginning. And this story started only 65 years ago. And so it's a story of a group of surgeons who sought to improve the outcomes after fracture. And so the impetus for this was that even 70 years ago, non-operative care and operative care fractures was highly unsatisfactory. Non-operative treatment did result in bones healing, as they have for thousands of years. But even when the bone healed, the results of the prolonged immobilization and non-weight bearing often resulted in essentially non-functional and painful limb. And this was because you had to immobilize for a prolonged period, resulting in a condition known as fracture disease, which was characterized by stiffness, muscle and skin atrophy, and circulatory dysfunction. So operative treatment actually was no more successful with a lack of adequate instrumentation, a poor understanding of how fractures healed, and then not good training for junior doctors about how to take care of these patients. So with that as a background, a group of 13 surgeons gathered at this hotel in Biel, Switzerland in 1958 and formed the AO Foundation. And so through this group, the AO principles were created, which still guide our fracture care and include fracture reduction, stable fixation, preservation of blood supply, and then early mobilization. And then additionally, these founders committed themselves to the education of surgeons on their techniques and on the instrumentation. And so in the early days, to get a set of instruments to fix fractures with, you had to attend an in-person course. And so since that time, through this group, fracture care has been completely transformed, and date almost 500,000 healthcare professionals from 160 countries have completed an AO course of some time. And so back to the original case, a 53-year-old male, Valdemar vehicle accident. So we described the fracture, AP view of a left forearm, skeletal mature patient, transverse proximal third radius fracture with a comminuted midshaft ulna, no extension, no associated injuries. Just one final hot tip. If you're assessing these x-rays, look at the radiographs for the soft tissues as well. And here we can see some bubbles of air within the soft tissues concerning for an open fracture. So Taylor, how would you fix this? What would you fix first? What would you be your primary versus secondary bone healing? Which would you choose?
So for this injury, we have a fracture at the proximal third of the radial shaft. That fracture is relatively transverse. And then you have a rather comminuted fracture of the ulna, sort of in the midshaft region. You have a star there highlighting what looks to be some soft tissue air, suggesting this is an open injury and would require somewhat urgent irrigation and debridement of the fracture site prior to fixation. And so that's something we would be considering, as well as the administration of tetanus prophylaxis and antibiotic coverage appropriate to the degree of injury. In this case, typically, I would say I would address the simpler fracture first here, the radius, and then that also gives me a stable arm such that I can flex the arm and then better access the ulnar border when I address the ulna. And the radius would be fixed with absolute stability because it's a simple fracture. And the ulna is a comminuted fracture that requires a bridging construct.
So you're telling me both? Primary and secondary?
Two bones, two strategies.
There we go. So yeah, it's possible in these, you look at each individual fracture, and in one case, we're going to treat the radius with absolute stability, anatomic reduction, compression plating, bridge plating for the ulna. So these are a couple of Christian's cases we're going to go through to apply these concepts. So Christian, kind of walk us through this case, primary or secondary bone healing. What would be your goal in this one?
Absolutely. I hope these cases kind of help us continue to bring home some of the core concepts you've gone over today. So again, here is a 50-year-old male. He's been in a motor vehicle accident. He's got an isolated injury to his left knee. Let's read the x-ray. Two views of the left knee, AP and lateral, demonstrating a comminuted split depression, partial articular tibial plateau fracture. It's a lot of words. Part of the articular surface is damaged. You can see the depression there. partial articular fracture to me says buttress plating. This is at the joint. So it's an articular fracture. I've been seeing some questions about strain, primary healing, secondary bone healing. At a joint, I'm partial to wanting primary bone healing and getting absolute stability. In this case, it's a partial articular fracture. I'm going to go for reducing that articular surface and using buttress plating to compress this fracture pattern and go for primary bone healing and absolute stability. So why don't we go ahead and see what we did here. And so I start off with the articular surface, tamping it up, trying to get it anatomic. I'm using a bone tamper to do that, holding that fracture in place with K wires that are coming from lateral to medial. All right, and then you can see more wires holding everything in place. I've got my reduction of the articular surface done. Now I want to compress and restore the condylar width of the plateau. I'm using a clamp to do that on top of my plate. And then the first screw that I placed here was my buttress screw at the apex of the fracture because that helps compress the fracture. And I think we have a pretty nice, close to anatomic reduction of the articular surface here using buttress plating. So at follow-up, patient has, I would say, an anatomic reduction. Yes, we used compression. The stability is absolute here. The strain environment is low, so we get primary bone healing.
Awesome. Let's do another one.
Yeah, I think we
So
got
sweet. I need more of Christian Payon's work. So what about this one? 70-year-old woman, ground level fall, maybe 1 acre, your favorite fracture, one of them, top 3?
I will say, not only do I love pertrochs, I love subtrochs, and this one, I think, as Christian is about to tell us, has some very unique features that could make a medical student a superstar if they were able to pick up on these subtleties.
Absolutely. Yes. Yes. So we've got 2 views here. One is pre-application of traction on the right, showing a transverse subtrochanteric femur fracture. After placement of traction, there's some features of this fracture that are that should clue you in to more of the history, even if you didn't hear it from the patient themselves. You've got some cortical thickening on the outside of this femur, and then you've also got that spike medially. Those characteristics are really encapsulate the atypical femur fracture, which is associated with bisphosphonate use. There's a lot of special considerations in these patients. Okay, you often want to get x-rays of the other side, see if they have similar kind of beaking and periosteal reaction from the bisphosphonate to make sure they don't have an impending fracture on the other side. You ask questions about that, right? Whether they had antecedent pain. Now, this is a simple fracture pattern, but like Dr. Aker was talking about earlier, this is a femur. This is a diaphyseal pattern still. We're going to use a load-sharing construct in this case. The right construct is a cephalomedullary nail, recon style. You can tune into the implant session that's coming up later to hear more about that. And that's what we did in this case. So we used a recon nail. I used numerous reduction techniques actually to make sure that the pieces were in a near anatomic position so that I could place my cephalomedullary nail here. You have 2 screws that come up into the femoral head. And I think this is interesting, right? Because we have a simple fracture pattern. We use a load sharing device. I would venture to say that the reduction is close to anatomic, but with the kind of device we use, what kind of healing are we going to get? 6 months later here, anatomic reduction, right? Simple fracture pattern. This was a femur fracture. We used a load sharing device. That's relative stability. That's a load sharing device. You're walking on this afterwards, right? So there's more motion at that fracture. And here we have her 6 months later, big old callus ball, no pain, walking. That's secondary. That's a functional reduction with no compression, relative stability. You can see that secondary bone healing. That's that big callus that came there.
Great. Really great example to Tim's point. The femur loves the nail. Just loves the nail. So, all right,
There was a question about load sharing versus load bearing. And so I don't, you mentioned the term, so I don't know if you wanted to compare the two a little bit.
Absolutely. So a nail in this case is load sharing. So that means that the bone is actually going to be bearing some of the load, and then the nail is going to be bearing another portion of that load. The stability in that particular case with a load sharing device is relative. So there's going to be motion there. A load bearing implant, more similar to what we had before, that plate at the proximal tibia, Okay, that patient, I don't put weight on it, weight on that leg, because all the force is going to be going to the plate, and I don't want motion at that fracture site. So those are contrasting two different types of implants and their function. Load sharing tends to confer relative stability. Load bearing is more of an absolute stability construct. I don't know if Dr. Aker or anybody else has anything else they want to add there.
Nope.
Great.
No, love it.
Let's do one more here.
One more.
55-year-old MVC, nice sizely thigh. On this one, it appears, looks like I see a little bubble of gas,
Yeah,
maybe an open fracture. So what would be your approach, primary versus secondary? I'm going to go ahead and click to the CT scan here, which is quite helpful.
Yeah, so this is a tricky one a little bit, right? Because we've got a metaphyseal distal femur fracture. We talked about how in femur fractures, maybe we're going for secondary bone healing, relative stability, but this is a fracture that's going into the joint. Okay, you actually have this sagittal cut of the CT that's showing a coronal plane fracture called a Hoffa fracture. Everything at the joint there, I'm thinking I want absolute stability. The joint doesn't really tolerate callus. You want to restore the cartilage. Small disruptions in the cartilage end up resulting in an altered biologic environment and progression of arthritis. So this is going to be a case where I want absolute stability at the articular block, and then I want relative stability across the femur metaphyseal region. So I'm going to bridge that region of comminution at the distal femur metaphysis after I've already used independent lag screws to confer absolute stability to the articular block here. So this is the immediate post-ops. I think we're all thinking, well, what are we going to get at follow-up? A combination of the two in one bone. You've got relative stability and anatomic functional reduction at the metaphyseal region. We compressed at the articular block. Okay, so if you look at the joint, you don't see fuzzy callus from motion and from secondary bone healing. That's primary bone healing, absolute stability at the joint. Okay, but then at the metaphysis, we have that callus and that fuzzy, relative stability and secondary bone healing. So we've got both here. And I think it's a nice example where you really have to think about the biologic environment and how each fracture needs to be addressed in a different way.
One of my favorite questions for a visiting medical student, how is this intra-articular femur fracture going to heal? And so you all have a little clue into that.
Fantastic.
All right, so we're wrapping up. I want to see, Taylor, any other questions that we should kind of dig into here in the last couple of minutes?
Yeah, for sure. So there's one question. I'm not exactly sure how to answer this here, but how do you predict whether a fracture is more likely to heal in varus versus valgus? I would say,
Tim,
I guess
Tim,
my answer.
give it to Aker. Mr. Valgus, is varus ever good?
Thou shalt not varus. That's the first commandment of orthopedics, y'all. But one thing you can do, I mean, this is to the anonymous attendee who asked the question. One thing you can do, certain fractures and areas tend to heal in certain deformities. And it's your job to obtain and maintain the reduction through union, not just in your immediate post-ops, but it has to be a durable reduction that'll last the next couple of months while the fracture heals. The other thing you can do, though, is look at the injury films. We really teach our residents about looking at that injury film. And if it's a distal tibia that failed in valgus and the injury film is in valgus, well, more than likely, if that fracture is going to have a problem, it's going to tend to fail back to where it started. So the injury films really tell a lot of the story. A lot of times we look at the splinting films and we jump right to nail or plate, but those injury films can be so telling. They really tell the story so well.
And then in the case of a really comminuted articular fracture, is that precluding your ability to obtain any level of absolute stability?
We'll work for it to get it, regardless of how comminuted. Now, there's sometimes where you're left with a hole in the femur, you're missing bone, different entity. But this is why some of these distal humerus fractures you see end up being 5-hour cases, because we're putting each little articular bit back together to preserve the joint. So.
And then Christian, you fix that with a plate, but we just said a femur loves a nail. Question was, did the fracture into the joint prevent the use of a nail?
That's a great question. For me, it often does prevent the use of a nail. Some people think if there's just a simple articular fracture of the distal femur, that they can independently fix this and are comfortable using a nail. There are some fractures like this that don't go into the joint that I combine both a nail and a plate. That's probably beyond the scope of this talk, but in this particular case for me, yes, the fracture going into the joint made me not want to use a nail.
Is this somebody that Tim knows that's poking the bear? We're sitting in the Tim is one of the greatest distal femur nailers in the world, I would say. And so I can see him about to jump out of his seat. So Tim, does going into the joint preclude you from nailing it?
Well, to be fair, that is a fair question. And
Yes.
the way that I was trained and educated in residency 15, almost 20 years ago, that was sacrilege. You did not nail through C-type or complete articular distal femur fractures. Never. Nope. You could explode the distal femur. That was the teaching at the time. And as our techniques have evolved and implants have improved and interlocking options about the articular block have improved, I think we've gotten better and better at nailing C-type or complete articular fractures of the distal femur. And so just to engage the students, to let them know what's coming next. I mean, yeah, I'm going to take issue with what Christian did here, because 100% of the time, I would have retrograde nailed this with similar Hoffa screws, with similar interlar condor screws, but I still would have nailed it. And for me, it's because that metaphyseal fracture that Christian has gotten to heal so well, I was having a lot of issues with bridge plating of that particular fracture. And once I started using nails, they all seem to do a whole lot better. So different ways to skin a cat, but that's why this is fun. That's why orthopedics is fun.
So Sophie Friedel was your burner account there?
Unless there's another one, Taylor, I think that's like the absolute perfect way. And again, I think shows why this is so fun in terms of fixing fractures, many different ways to achieve a good result. And then we get to kind of talk about it and rib each other a little bit. So I want to just finish with a little bit of a teaser just by showing this case. And so next month is Implants 101. This is a 65-year-old guy I took care of. He was 3 months out from getting his femur fixed at an outside hospital. He just seen his surgeon, just cleared to start putting weight bearing. He took a step in his garage and felt a pop, couldn't walk, and came into trauma clinic with this. Last patient of the day, really a true gift. And so this seems wrong to me. Plates, I feel like, should probably last longer than 3 months, definitely more than one step. So why did this happen? What did this surgeon with 20 years of experience do in this case to contribute to this? So the answers to all those questions are going to be discussed next month. And I just want to click back to this thank you link. Thank our faculty who are on tonight, all the participants. Again, we crave the questions, so helpful to kind of further discuss some of these points, make sure we're getting these messages across. And I just want to thank you all.
Nice job, Phil, Taylor, Christian. Thanks to the AO staff. See y'all next month.